So, welcome to our realist evaluation on optimum hospice at home services for end of life care, which we've called OPAL. And it's a realist evaluation that included co-production embedded throughout the 3-year multi-site study. So, just as a very brief background, hospice at home services aim to enable people to have a good death at home, and this accords with UK policy, but statutory services are ill-equipped to meet demand, and there is increasing demand for dying at home. But there's also very limited evidence from the perspective of people using the services, either as participants or co-producers, of what actually works best. So we reviewed the literature and we found a lot of variety in services. Different outcomes were used, and it's quite difficult to ascertain what works well for whom and in what context. So that led to our study question, or the overall study question, which is what are the features of hospice at home service models that work, for whom, and under what circumstances? So it was a 3-phase study. The first phase was a national survey of hospice at home services, and 70 responded, and they identified a range of service models and characteristics. So, for example, urban or rural setting, the staff mix of registered nurses to healthcare assistants, whether specialist nurses were part of the team or in a separate team. So there was a lot of differences between referral criteria, service size. So we developed a typology of care in consensus with stakeholders. And we use that to select and invite case study sites for the next phase. And we started to test initial context mechanism outcome, or CMO configurations. So the next phase included data collection from 12 case study sites across England. We used a mixed method, so qualitative data with realist-informed interviews with carers, providers, and that include commissioners, CEOs, policy makers, district nurses, and 10 commissioners. So quantitative data was collected we recruited patient carer dyads, and we collected particular measures of care and outcome indicators. For example, our primary outcome measure was the quality of death and dying. And we also collected health economics data on service utilisation. So, for example, how many visits of which type of professional per week, how much informal care was provided, what equipment was provided. So quite very detailed information collected from recruitment to death. And then we carried out an interview with the carer at a later date as well. And then the third phase was refining our CMO configurations, and we held 2 national events plus some smaller preliminary events, and that guides our recommendations for NHS England. And at the moment, we're just finishing the report. We've been doing some dissemination activities, and we are looking for further funding for impact activities. So why did we think about embedding co-production into realist design? What are the attributes of both that meant that they meshed so well? So we know with hospices they have a lot of people involved. So obviously patients, carers, family and hospice employees, but a lot of people in the community volunteer for their local hospice, and it was important to capture their views as well. Other third sector organisations like befriending services, obviously health and social care, particularly district nursing and GPs, commissioners and policymakers. So each stakeholder group will bring a different cognitive and emotional representation on that issue, shaped by their own experiences and interests. So it's important to represent those different interests. and to build relationships with all the stakeholders so that we became trusted partners over the 3 years, and that they then engaged in the consensus events in the very final phase. So the ontology of co-production emphasises the importance of engaging and integrating the multiple perspective of stakeholders that can shape understanding and the process of knowledge generation. So that they're part of that process, and that really accords with the realist view of different perspectives and meshing those and using those to generate theory. So probably worth just thinking about what do you mean by co-production rather than public and patient engagement. So co-producing a research project is an approach in which researchers, practitioners and the public work together, share power and responsibility, and are included in knowledge generation. So all those assets that you can see there, like respecting each other, reciprocity, building relationships, that was very much part of our process. So if we think about all those different stakeholders and their different perspectives, that links really well with the realist view, particularly Basker's view on ontological depths, and that's why we've got our iceberg reminder. It also links with the idea of abduction, or the inventive thinking required to imagine the existence of such mechanisms. So as researchers, we would only think of a certain number of creative links of mechanisms to outcomes. Our stakeholders helped us think much more widely, and also then to test those ideas. And retroduction, uncovering the causal mechanisms. So inference to theorize and test hidden mechanisms. So that, a cross between abduction and retroduction. And different perspectives widened our creativity. And I think that was a really key benefit, was that creative thinking in different perspectives. So bringing it back to our 3-phase design, we started with a literature review. We looked at hospice core standards, and we used normalization process theory to help develop program theories. We had our survey and our case design with our mixed methods of data collection. We then started to map what we found to develop our CMO configurations and to test iteratively, which really took a couple of years, which was part of that refinement as the consensus activities. And the co-production had different aspects to it. So we had an expert stakeholder group that included representations from Public Health England, from hospices, commissioners, policymakers, that wide remit. We had consensus events, which included a lot more frontline staff and patients and carers. And we had 2 co-applicants who were lay members who were involved right from the start. And they really got involved in theory building. So building our program theories, not just commenting as you might do with a more public and patient involvement role. So this is Graham and Mary, both very experienced, both very committed to the project throughout. At the outset, our role was far less hands-on, but as the project progressed, we wanted and felt more confident to be more actively involved. And to do this, we had training at different stages. And as Graham says, the team had to be very accommodating to our frequent presence, which was really helpful because they questioned us, they prodded us, why are you making that assumption? Have you thought about? And that was really important with building up and testing our program theories. So I carried out some additional qualitative data analysis training, and we talked about realist philosophy. We had a go at coding interviews. That fed into regular coding meetings where we used normalization process theory to start with, but then we sort of moved beyond that stage and it was less helpful. And we were really grounded in our transcripts. So Graham and Mary used different approaches. So Graham was much more keen on using the audio as well as the transcript. And as he says, I valued access to audio files along with typed transcripts. I believe coding of carer interviews in particular were better evaluated when listening to interactions between respondents and researchers, understanding tone and timing. So he really brought out the subtlety of certain comments that we all picked on. We all thought, oh, that's a really important point, but he was able to ground it in that more emotional non-verbal communication as well. They used different approaches. Graham was particularly good at stepping back and providing an overview and a narrative of a particular carer's experience, whereas Mary was much more into this detailed coding. So the research associates, myself included, we coded all the interviews in NVivo. The senior, PI and CI, Graham and Mary and Charlotte from Pilgrims, tended to code by hand on the transcripts. And then in the meetings, we used a document, of which this is an excerpt, where we kept amending our our CMO configurations iteratively. So you can see the different colours represent track changes. Red is an unintended outcome. So for example, for this volunteer one, volunteers may find the structure and expectations too demanding and inflexible and choose to take their volunteering skills elsewhere. So there was a lot of detail, and this is version 23 that was pages and pages long. So it took a lot of iterative refining over 18 months. So benefits of co-producing. Graham and Mary were really involved in building and testing our theories, and they provided a fresh eye and a different perspective, particularly useful when thinking about the relationship between providers and carers. So, for example, sometimes there were quite big expectations of carers, like managing medication, that hadn't really been discussed fully with them. And I think Graham and Mary were better at picking up those assumptions than we were, because we were much more involved in the nitty-gritty. They had more personal experience to bring out those subtleties, and also the changing relationship between patient and carer as the illness progressed. So as Mary says, I became more familiar and confident in my ability to code and to data analyse, and I found it very satisfying to feel I was contributing directly to the actual coding. So phase 2, we came up with these key programme theories, and we all read and discussed nearly all the 143 transcripts. So you can see how we've divided into doing the work, keeping it going, and then the impact for the individual. So that's what we took forward into the consensus event, which was held in London and Leeds, luckily before lockdown, so last January. And we advertised as widely as we could through Hospice Network, through volunteer organisations, through personal contacts. Some of the carers that we were involved with were interested in attending, although very few actually did, which I'll come back to later. So the format was a day where in the morning we discussed specific CMO configurations. In the afternoon, we looked at it more as an overview, and we also asked people for ideas on dissemination. So I'll give you just an example, a flavour of what we did. So in the volunteer workshop, there were 4 key areas that came out. So one of which was, how can hospices provide clarity on the role and remit of volunteers? So, for example, how can the hospice ensure that this clarity protects all involved without being unduly flexible? And we gave them example quotes from the transcripts. We divided into groups. They discussed these areas of, problem areas. We came back, we looked at the specific CMOs we discussed. We took notes throughout. So for each group, there was at least 2 facilitators. So one could take field notes and the other could facilitate. So we got a lot of rich data that we collated into a report from the consensus event. We also devised, here's an excerpt from one of them, a paper example, where we listed the mechanisms. We asked people what approach they're already taking, and to tell us more about how they did that. So for example, the third one, a secondment into different setting may facilitate integration by the learning of another language. So that was where there were secondments, for example, between district nursing services and hospice at home services, and that really facilitated understanding each other's language and integrating services. We had a similar format for sustainability, so there was a lot around the importance of reputation and selling your business plan to commissioners to try and generate more funding, although that rarely came into fruition. So most hospices only received about 25 to 30% of their funding from commissioners. The rest was their own fundraising. So sustainability was a key issue. The carers workshop was more informal. So we broke down the CMOs into more informal language. So for example, how can hospice at home support you as a carer? And what will be the result of getting the right support? So that's obviously your outcome. We also had a CMO speed dating, which was in the afternoon, where we had the posters all around the room. We gave people post-it notes and got them to just walk around. So after lunch, or a good idea, wake you up a bit, talk to your colleagues, talk to the research team. And again, we took a lot of field notes of discussions, and we also then collated all the post-it notes into the consensus document of what people said. So I think people really appreciate time to network and swap ideas between different service providers and services. And we kept people on track with ringing our bell every 15 minutes. But that worked. We were a bit nervous about doing that, whether it would work well, whether people would feel they'd had enough of CMOs, but it worked well. And then allied to that, we then talked about how best to disseminate. So the only problem was limited engagement from carers and patients, and that is as you expect when you're talking about end of life. So while some of our carers that we'd interviewed had said they wanted to attend, very few did. And as Graham says, stronger representation would have really helped inform service providers of the challenges. I think both ways, the challenges that carers experience and the challenges for service providers, particularly now in COVID circumstances. So just focusing back on Graham and Mary, they had a research facilitator, Charlotte, who stuck with them through the 3 years and really helped them engage. She was there for any queries at any time. She helped with training. She helped with practical things like expenses and the, filling in forms. But she also filled out or had an activity with them where she assessed what their impact was after each so for example, after attending a project management meeting in December, what was useful? So they were able to keep up with the project progress and contribute to discussions, and they're also able to review their own contribution to coding. And out of that, the outcome was that they reviewed how they coded, and Graham took a more narrative view of the transcript, whereas Mary stuck more to the nitty-gritty of coding at quite a detailed level. And September they started coding, so one excerpt from the report was that we reconfigured CM09 based on his feedback. So it's really important to keep tabs on what they do, what are the outcomes, making sure they feel supported and they feel part of the team and they feel listened to, and that we respond to any requests. And certainly when I joined in phase 2, they really were part of the team. So to conclude, it worked really well. The co-production approach married with the realist evaluation both really helped the other. Graham and Mary were particularly skilled, not just at coding the data, but at integrating with the team, or feeling confident to suggest things. And they really were equal team members, and I think that's really important that that's formalised. They both said it was really important to have Charlotte there, who was always available to provide guidance, support and encouragement. I might have struggled without Charlotte's help, and any team using this approach would be wise to have this support role in place. So you need to budget for that, and we had a generous budget, a day and a half for Charlotte's time throughout the project. You need to be very clear about your expectations and have boundaries, so you both know, like Graham and Mary were putting in a lot of time to preparation for coding meetings, and that time needs to be acknowledged and remunerated. And it is a big personal investment, particularly a 3-year project, and I think it's really important to talk that through at the start. The co-production really enhanced data analysis and trustworthiness. It really helped with generating and testing theories. And for such a complex intervention as Hospice at Home, it was a really good fit between the realist approach and the ontology of co-production. And finally, just to say a big thank you to Graham and Mary, who also helped with this presentation. Thank you very much.